I wanted to talk a little bit about our model at Cleveland Clinic for multidisciplinary care of patients with MASH. We have an innovative, multidisciplinary, cutting edge MASH clinic where we see patients with MASH and clinically significant fibrosis. So F2 and beyond, F2 all the way to cirrhosis, compensated patients who have had liver transplants associated with their MASH cirrhosis, sometimes patients who have had transplants and the MASH is affecting their transplant to liver again. So really a big spectrum of patients suffering from MASH. And the way that the clinic works is that we get the patients referred to us and then we see them in tandem. So I see the patients for their metabolic management, diabetes, obesity, lipids, blood pressure, sleep apnea, all of those things. And my co-director of the clinic, who is a hepatologist, she sees the patient for the liver-directed pieces and screening and liver-directed therapies. She orders additional testing and imaging when it's necessary to clarify staging. She monitors the progress liver-wise, while I monitor the progress, for example, diabetes-wise. So not only we collaborate and communicate, but we are literally working together thinking about a treatment for the patient. So I think that has been really, really helpful for the patients. It saves the patient's time. It saves us time. We also collaborate very closely with bariatric surgery. So we are able to refer patients and schedule them really easily. So once the patient comes into our clinic, we essentially coordinate their care so that there are no delays and patients don't fall through the cracks, or hopefully to diminish the number of patients that fall through the cracks.
Yeah, I think we have a great clinic, and thank you for sharing about that. And I think that there's different models. We're really fortunate. We have such a robust team here at Cleveland Clinic, but there's also different models for those that don't have an interdisciplinary clinic. I think the key thing to get across is that any person, any healthcare professional that's seeing people with diabetes or with obesity or at risk of MASH, just do at least the FIB4 screening and then know where you can refer to so that we can catch this much earlier and hopefully help people really get the therapies that are going to benefit them and prevent any complications, ideally prevent fibrosis and definitely prevent cirrhosis.
Absolutely. And as you were saying, Dr. Isaacs, I think that the role of the PCP in the initial provider who initially encounters this patient with metabolic disease is absolutely critical. That provider, there's a lot of room for the PCP or the referring clinician to do a lot of the workup already and get the patient started. You mentioned the FIB4 for sure. If you have access to something like a BCP or elastography, if the FIB4 is more than 1.3, I think that's really helpful. And it helps us risk stratify the patients so that patients that are at higher risk go to the hepatologist, but patients that remain at lower risk continue to have their metabolic management at the PCP's office. So it helps us really refer patients that need it and not refer patients who just need metabolic management, which can be done by the endocrinologist or the PCP.
Yeah, and I think the key thing here is that we're all a team together. So the referring clinician is referring for the expertise. In Diane's case, she needed the diabetes management piece also, and of course, continue to follow with her endocrinology team as well as the hepatology team. So I think the key is the team-based communication, keeping the person at the center of all of it and making sure that we are empowering them, letting them know the therapies available like resmetirom and giving them the choice to take these therapies that can really potentially improve their condition.
What I'm seeing in my clinic is patients who received liver-directed therapy, like a liver transplant from complications, but they didn't receive the metabolic management that they needed. And therefore, now they have a transplanted liver that is becoming steatotic again, that is developing hepatitis again. And these patients that are at risk for having cirrhosis with a new liver as well. So we know that if we don't manage the metabolic conditions, the patients can recur and the disease cannot be treated. So it's really important to remember that MASH is really a liver manifestation of a metabolic disease, not really a liver disease per se. So this remains critical.
Thank you. That is a great point. I want to thank you for co-leading this. I want to thank our patients for joining us and sharing their journeys. And thank you to all the viewers who have listened to this, and we hope that you have found it helpful.
Thank you for having me.